knowledge and time with one another. May the speakers be blessed as they continue to bring their experience to our society and to our world. Bless each of us gathered as well, so that we may be able to glean information from this event. May we realize that all we do should glorify your name. Amen. At this time, I wish to express our appreciation to the sponsors who made this event possible. The Sisters of Charity of the Incarnate Word, San Antonio, the Congregation of Divine Providence and Providence Trust, San Antonio, Christus Health from Irving, Texas, the Dominican Sisters of Houston, the Sisters of the Holy Spirit and Mary Immaculate, and the Oblate International Pastoral Investment Trust. And a special word of gratitude to Esther Ng for the donation of the award. The next part of the program will be first the presentation of the award, followed by the presentation of rising cost of health care. And this will be the third year that we have presented the Citizen Advocate Excellence Awards. And I am honored to introduce tonight's honoree, who is one of my own sisters, Sister Frances Lorene Lange. Many of you are aware of Sister Frances Lorene's influence in the creation of SRIC. It was a dream of hers after she was inspired by a talk given by Father Mike Crosby, Capuchin Franciscan, in 1974 to the LCWR annual meeting. He challenged the religious members in the audience to pool their invested resources as a catalyst for social change. Sister Frances is a strong believer that we can use our financial resources for good, and there is people power in the marketplace. Throughout her 69 years as a Sister of Divine Providence, Sister Frances Lorene has served the congregation as a primary school teacher, counselor, formation director, member of our General Council, missionary to Ghana, Africa, retirement center coordinator, and many other roles. Sister Frances Lorene has always been a supporter and encourager of the work of SRIC. And for this reason tonight, we honor you, Sister Frances Lorene.
Good evening. So many years ago, when I think of my age now, then I think, oh my, I was young, innocent, ignorant, and just full of volunteering and energy. So it's like this is many years later. So I think where I want to begin is that as a long time ago member of LCWR Region 12, and as a Sister of Divine Providence, I accept this reward in the name of all of us. And I have vivid remembrances of Reverend Michael Crosby Capuchin Franciscan. Once more, that was not the first time, once more coming to Region 12 LCWR, explaining the importance of the National Catholic Coalition for Responsible Investments. That was the full title once upon a time. And this organization had been highly successful in the Northeast. And he saw such potential in the South, and he wanted to come and encourage us, ask us to begin such an organization down in the South. Here we are. Yes. And at every meeting, I think he came twice, and each time he asked the same thing. And at this one meeting, he said, now we have to have a volunteer. Would someone take the leadership and help this happen? And sat there for a while. We all sat there for a while. And he looked at us, and finally, I put up my hand, and the rest, that's why we're here. And what else I want to say about that? It was not until Sister Susan Mika, where did you go? Susan, there she is. It was not until Susan Mika got on board and that this organization it was an idea, it was a dream. It was a commitment that we had made, but we weren't really getting it off the ground in full function. And here comes Susan with new energies and new skills, and then SRIC is born. So it's a long history. And when I look at you in the room, it's really Susan and all of you who all these many years have carried the organization. You have brought that original dream to reality. And it's still being lived out now. You are the ones. So this award, I feel, belongs to all of us together. Everybody in this room has earned the award. And I thank you for that. And I think you should give yourselves a hand for those many years of hard work. And as a long time ago mother foundress, as I seem to be called, I just encourage you to keep on keeping on. It's such a worthwhile thing. It's a justice work. It's an advocacy work. It's a way that we religious organizations can still have power to make a difference. And we take our investments and they help us do good things. And so I thank all of us for doing that. And thank you for the honor. God bless.
And now I ask Sister Anita Brennick, a member of our CDP leadership team, to share a few brief remarks.
Thank you, Patricia. And thank you for everyone sitting here. Like she said, I am Sister Anita, and I'm here to speak in behalf of our congregation, much broader than myself, our table full of CDPs and associate here. Could you wave your hands where you are? I think everybody knows you. And on behalf of all of us CDPs, we appreciate the award for Sister Frances Lorene. We're pleased, so pleased with all that she has done for us, but more so for so many in our world. And we're glad she's a part of who we are and who this group is. You know, as I reflected on this, when Patricia told us about Frances Lorene receiving the award and we CDPs coming with her, I thought how right it is, because we began our founder, much like the founders of all our congregations, for doing direct services for people in need. Religious life is called to keep looking, as Pope Francis has said, for those on the edges, the marginalized, and what needs to be done now in our world. And Blessed John Martin Moy started that group of women going out to those little countryside places where the girls and the women didn't have the opportunity for education. And then 100 years later, Mother St. Andrew came here to Texas in this frontier land. And it was right after the Civil War. And she began schools in a lot of little country places, little rural areas, like had happened in France, but also in the cities, San Antonio and Houston and Dallas. And she also started schools in Louisiana for during that such segregated schools or no schools for the children of the descendants of the slaves. She started schools there and some in Oklahoma for the Native Americans, and all that direct services that would help lift people's lives. And as time went on, we began seeing for sure about all the children who weren't in the Catholic schools and our schools. And so we moved into religious education and then parish work and then social work, starting a school of social services, as most of the congregations have done here, continued looking at how we serve rising needs. Currently, partially because of our ages, as well as the needs changing, we're more involved with community organizing as we help people pull their numbers and their strengths together for others. And so in light of that, it's obvious to me, we've really moved into more advocacy work as well as the direct services, as Catholic social teaching calls us for, that we do both and. And thus, we've been involved with this organization as well as many others, thanks to Francis and Patricia's work and the work of so many of you sitting here. We're very pleased to be a part of this SRIC, SRIC, Socially Responsible Investments Committee, all the different ways that we work for the good of those who have less voice than some of us. Because we value working, we CDPs and the congregation sitting here value working with the variety of us, I want to take this opportunity to invite each of you this Sunday, if you're not committed to your parish ministries, to a 2:00 Mass at Our Lady of the Lake Convent in our beautiful Sacred Heart Chapel. Every year we have that Mass with honoring not only our founder, Father Moy, but living Providence today, as we live Providence, as we share the charism of Providence with all of you. So you'd be welcome to join us 2:00 in Sacred Heart Chapel as a way of our saying thank you. Thank you for what we do together. Thank you for what SRIC does. Thank you for us getting to collaborate together. And thank you for recognizing who Sister Frances Lorene is for so many of us. Thank you.
Yeah, I now invite Anna Falkenberg, the Executive Director of SRIC, to make a few brief comments.
Yes, I am Anna Falkenberg. I'm a former university professor. And when she said brief remarks, I went, better cut back on the lecture. No, I'm so pleased to be up here telling you just a little bit about our work. You know our work well. You have made our work possible and continue to do so. So I'm just really pleased to welcome you all, especially Sister Frances Lorene Lange, the winner of our Citizen Advocate Excellence Award. Her determination is an inspiration, I think, to all of us, continues to be, and the members of the Congregation of Divine Presidents. And we have with us tonight our distinguished colleague, Bishop Michael Pfeiffer, who celebrates this special day with a statement called World Earth Day 2025, focuses on our planet and our power. Here it is, and we're going to have copies of it for you as you leave. It's a powerful statement. Today is Earth Day. All kinds of information in here about things you can do. And he is, I think, a great champion of environmental justice and has been for many years. So, Bishop Pfeiffer. Thank you. Thank you for being with us. We are missing Father Seamus Finn. He was unable to join us today, but he sends his love and gratitude to you all. And I'm going to have him join us in May and give him the platform at one of our board meetings to talk about all the work that he has been doing and is doing always. So we'll hear more from him later. My work with SRIC has been global in reach this year. As I serve our mission, and what we do for you is to empower you as faith-based investors to build a more sustainable world by advocating for corporate responsibility and accountability. We've been doing this for 43 plus years now. In November 2024, I was honored to be invited to the second Mensurum Bonum Conference on Faith-Consistent Investment. This is an international conference first held in Rome in 2023, which I attended as well. And it has been sponsored by the Pontifical Academy of Social Sciences in the Vatican. Of course, our colleague, Father Seamus Finn, has been instrumental in developing and guiding this movement. Well, this year, the meeting was in London, and it was hosted by CCLA, which is an investment fund for the Church of England. So we're moving out, reaching our other faith-based colleagues in the world with the movement. And the focus of Mensurum Bonum is really applicable, I think, in many faith settings. It's an investment theory that allows organizations to align principles from Catholic social teachings and apply recent papal documents to create a culture and economy promoting integral human development while maintaining their fiscal duty as investors to attain prudent returns. You know, we work as investors, and as investors, you all have fiscal responsibility, right, for return. And yet you want to do good and do well with the money that you have. And it's that commitment that's allowed us to do the work we do and continue to do it. I also serve on the Interfaith Center of Corporate Responsibility. I also serve the Interfaith Center on Corporate Responsibility as a member of the board of directors. Those of you who don't know ICCR, it's not truly our parent organization, but it's our national organization of groups of like SRIC and all sorts of all sorts of members. But the membership of ICCR has become global, very diverse community, institutional investors, faith-based organizations, asset managers, labor unions, pension funds, foundations, and other like-minded investors collaboratively representing over $4 trillion in assets under management. So that's the power that we have when we go into company settings. When we talk to companies, they know about money and they listen to money. And we can come with that kind of sizable asset to tell them we want to make changes or we want to influence their behavior in some way. And so We now, though, at ICCR and I on the board, as well as our other board members, are seeing that we're meeting challenges and threats posed to our shareholder rights, and as well as we're looking forward to creating a more sustainable future. So our board is working very hard to counter the threats that we're beginning to see to our work. There are those who do not think we should have any shareholder rights, and that we don't need to be talking to companies about the behaviors that they're doing. But back to SRIC. Our main work here is to educate you on corporate behavior tied to our issues of concern, governance, the environment, and social issues. And we assist you as investors to speak to companies through direct shareholder engagement using proposals or resolutions, company dialogues, and multi-signatory letters. You may wonder how these many years, these many engagements all through the years continue to speak to companies. Why do they listen to us? In many cases, we provide them with really valuable information about assessing and looking at their risks. But another reason is this is a quote from the ICCR, why do shareholder proposals, why are they good? They make good business sense. And so we present a business case in many cases to companies. This is the quote. Shareholder proposals are one of the few opportunities that ordinary American investors have to raise concerns about business risks with the companies that they own. A shareholder's right to place proposals on the proxy and the freedom to express a collective voice by voting on such proposals are part of the social and legal compact between investors and companies that maintains the trust needed for capital markets to thrive. That's what we do. Despite these great benefits, as I've said, and other benefits of shareholder engagements with and to companies, critics are working to take our right away. And at ICCR, we are going to companies continually to say, please respect and support shareholders' right to file proposals. During this filing season, which is a season where we make the proposals or resolutions or have dialogues or send letters, and then eventually those proposals, we would hope, end up on the proxy statement so the shareholders as a whole can vote for them. During this filing season, we have over 200 proposals that were filed. This comes from ICCR's proxy book, and were filed to be on the company's proxy statements. The topics that the shareholder proposals spoke to were in this order: human and worker rights, corporate governance, lobbying and political contributions, diversity, equity, and inclusion, climate change, environmental health, and health equity. And that's our program tonight. Since we're going to be looking at health equity, I'm going to highlight just some of the proposals that from this last season that were on health equity topics and or nutrition and security. This year, the proposal topics in the area of health equity range from human rights and various forms of human rights, policies, data protection and privacy in the medical field, very important, to, and I'm not demeaning this, but down to non-sugar substitutes. We have been talking to many companies about the products that they make and the methods that they make them being very actually unhealthy to many consumers. and non-sugar substitutes, as much as most of us want to get away from sugar, of course, are almost as dangerous, maybe more so than sugar. The companies receiving these resolutions this year were United Health Group, in the news, Moderna, Eli Lilly and Company, AbbVie, heard of some of these? Johnson & Johnson, I think you've heard of that one. Merck and Company, Amazon.com, Walmart stores, Mondelez International, Kraft Heinz Company, PepsiCo, and for many years on many topics, the Coca-Cola Company. So that's just a small piece on one topic of the companies that we have been addressing with our shareholder proposals and pleas for action and change. So I think now that brings us to learning more about the dynamics of health equity. We are so privileged to have a group of experts with us tonight to explore the rising costs of healthcare and other issues around healthcare access and health equity. But before we move to the panel, I do want to take a moment of personal gratitude just to share thanks, especially very sincere thanks to our members at Christus Health, especially Gabriela Syons and Shara Abrams. They were not able to be here with us tonight, but their colleagues who are. To Sister Letty and the Sisters of Charity of the Incarnate Word for supporting and mobilizing us, I think, to move into this topic. To Lydia Kuykendall with Mercy Investments for visioning and creating this program. And of course, sincere thanks to my excellent assistant, Ruben Lopez, for making it all come together. So now back to Sister Patricia, and we'll move on to our panel. I know you've all been waiting to hear them, so we're all looking forward to learning more about health equity.
Thank you, Anna. I now invite our three speakers to join me on stage. Dr. Derek Rodriguez, the clinical research scientist for the Institute of Health Promotion Research, Department of Population Health Sciences at the University of Texas Health Science Center at San Antonio. Lydia Kuykendall, the Director of Shareholder Advocacy at Mercy Investments Services, and Will Schneider, co-founder and CEO of Metopio. Thank you. Okay, so enjoy their presentation.
All right. Good evening, everyone. How are we doing? Good. Well, first and foremost, I would like to thank everybody here at the Social Responsible Investments Coalition for having me here today. Today, I would like to discuss some of the determinants that we are addressing in our current research at UT Health San Antonio. And it's more so to improve health equity in patients, but most targeting cancer survivors. But before I move forward, I would like to kind of paint the roadmap to where I ended up to where I am now. I am now creeping up now on my 22nd anniversary of being cancer-free. And this, oh, thank you. And I believe that as a pediatric cancer patient, this kind of set the precedence to, be more health involved, be more of an advocate for not just pediatrics, but all patients in general. And even more specifically in our Latino population, which are pretty much underrepresented to even this day now being 2025, and amongst other underrepresented minority groups. So this is something that we strive for at the Institute of Health Promotion Research, and I will tell you more a little bit about why. So Latinos are growing rapidly here in the States, and now they make up 19.5% of the US population, and this is expected to grow significantly higher. We're the minority majority here in Texas, and especially in San Antonio. By 2060, we're expected to grow by 27.5%. And with this unique growth comes several challenges, including lack of culturally appropriate healthcare, lack of early education, health literacy, and overall higher rates in late stage and diagnosis, and ultimately leading to worse health outcomes. And as you can see, Latino overall have a heterogeneous or a very diverse background, reflecting profoundly in the different adverse ethnicities, cultural origins, yet we're still overall poorly understood and often invisible. And so this makes studies, to tackle them in clinical research and clinical trials very difficult overall. And so a lot of this is much more needed. Many face challenges like non-medical drivers of health, more formally known as social determinants of health. And this involves food insecurity, low health literacy, as I've mentioned, geographic isolation, especially in the rural areas of South Texas. Poverty and income inequality. 1 in 3 US Latino families live in poverty to this day. Low or uninsurance, no safe places to play for children, food swamps. They have to travel far ways away in order to go to a nearest grocery store. Less safe streets and inequitable access to early education. So about 42% of kids are in childcare deserts, similar to what we see in food deserts. And overall lack of tailored health outreach. And overall, these health inequities in non-medical drivers of health are all directly influenced in disease and the cancer care continuum, which is something that we highlight in our institute. And we address cancer health disparities overall for families and people of color, leading that will overall shine a light in what these health outcomes and why are they more limited in this population. And overall, from obesity to COVID, dementia, and cancer, you name it, there's a lot more limited resources. Latino cancer cases are now expected to increase by 142% by 2030. And these estimated cases ultimately are from the new American Cancer Society data. And many of these numbers are growing up depending on the cancer types. Post-COVID also, we saw an uptick in the mental health needs. For example, 1 in 3 mental health conditions would seek treatment, especially during this time. And many families in the community have the lo resolvemos en casa mindset, which just means we'll solve it at home, right? We don't need the help. So cultural barriers over time have a lack of, are involved with the lack of Spanish speaking providers, which makes sense because if you're going to go to a doctor, you're going to go talk to somebody that speaks your language. But when that's not available, you're going to resolve it at home, right? So ultimately, there still needs some sort of integration tactic overall. Most research kind of embeds the community health worker or promotores sciences, but ultimately we don't see that working, and we're still trying to solve as to why. Do we need more community health workers? Do we need more patient navigators? What is it? I mentioned before geographic burdens as well, right? There are rural, there are border areas that lack specialty cares, right? In these areas of healthcare deserts. Difficulty accessing transportation. If I don't have a car to get to my appointment, then I'm not going to go, or I can't go, right? And so a lot of these kind of ultimately lead to the lack of regular primary care providers, which ultimately would help with screening, right? And preventing cancer overall. And then I mentioned language before. This is something that we need to seek. Do we need more interpreters, you need providers that speak fluent or bilingual um, uh, languages, for example. And so a lot of this may lead to lower satisfaction and worse outcomes. I want to highlight what is a cancer survivor. Everybody assumes that once you complete treatment, you're a cancer survivor. But in fact, you're a cancer survivor the moment you are diagnosed with it and living with cancer. Up until the moment that you are recovered, you are still considered a cancer survivor, according to the National Cancer Survivor Day Foundation. There's a good news story overall with cancer survivorship, right? As basic science advances, we are now seeing more treatment modalities, and we are experiencing a 45% increase in cancer survivorship since 1979. And this is expected to surpass the 22 million by 2030. And so the 5-year relative survival rate of cancer, combined with all these other substantial advances in medicine, we're able to see great significant advances and diminishes in cancer types and stages. Also varying in cancer type, we see more survivors that are being breast cancer survivors, prostate cancer survivors. The National Cancer Institute estimates that cancer-related direct medical costs in the US are 183 billion in 2015, and this is projected to go up by 246 billion by 2030. So this is a 34% increase based only on population growth and aging. We talk about health-related quality of life, right? So this is basically some of our major perceptions of well-being post-cancer life or even during their diagnosis. Only 1 in 4 survivors have physical problems, while as 1 in 10 experience emotional problems. And so this is magnified in the Latino population, structured by these inequities and limited access to follow-up care and clinical trials. Many people worry about how they're going to cope with their cancer, amongst other things, and they have fears about what their future will look like. They may wonder, am I going to die? What is going to happen to my body? They may no longer feel safe. They feel exposed, vulnerable. At the external level, they may think of what's going to happen to my family, my job, insurance, finances. The number 1 fear in cancer survivorship is reoccurrence. I know this is one of my fears to this day. And so once you have a cancer diagnosis, there are greater risks of it reoccurring if the underlying issues are not addressed, for example. And this is expedited or increased due to smoking, poor diet, and excessive sun exposure, drugs, and alcohol. And so overall, I would like to mention that survivorship overall in the Latino community can be poor due to low education levels, no insurance, little to no insurance, and no source of primary care. And overall, even with proper access, they experience these disparities in treatment options, right? A lot of them don't know what treatments are out there. And so this limits the inclusion of clinical trials as well. Overall, there's just no study anywhere in the world that looks to unpack the survivorship in the Latino community and their journey until now. So in our study at UT Health San Antonio, we are the first cohort study that looks to unpack the survivorship journey of Hispanic Latino cancer survivors. And this is done with the Avanzando Caminos Hispanic Latino Cancer Survivorship Cohort Study. This is the first of its kind national study that looks at these survivors funded by the National Cancer Institute, that looks at the behavioral, psychosocial, biological, medical, social influences on survivorship. And we're addressing those non-medical drivers of health that I've mentioned before. Overall, this study is led by Dr. Amelie Ramirez at UT Health San Antonio. And it's a nationwide study because it's in collaboration with the University of Miami Sylvester Comprehensive Cancer Center. And so overall, we're working together to enroll 3,000 Hispanic Latino cancer survivors, overall unpacking the Mexican American and Latino populations across 8 solid tumors. We're expecting to partner with other cancer registries as well in order to recruit eligible participants. And we have aims that build on identifying these modifiable mediators and lifestyle behaviors and biological markers. Because as Hispanic Latinos, we can be European, we can be African, we can be Caribbean. The heterogeneity and our predisposition to cancers are not well understood. So this study is going to look at the genetic predispositions as to why these cancers are occurring in our population. Overall, we're looking to recruit in a variety of different avenues, health system clinics, hospitals, private practices, websites, social media. We've been on KSAT a couple of times, and we're still continuing to gather an influx of interested individuals through this avenue, and as well as community events. So if you see us at any event, we usually set up booths with the team and identify potential survivors that way. We've already recruited a little over 1,000 participants, both in South Texas and South Florida to this day. And all the participants or patients each bring unique stories to the barriers. Again, we do not provide any medication or interventions. We just want to listen to their story. And from that story, we collect the data in order to identify potential interventions that may not otherwise be available to this state, such as more support groups, better provider assistance. How do we educate providers to become better at culturally bedside manner aspects? Within this study, we have identified also that there is a likelihood of reporting perfect, right, healthcare based on language and other factors. So as we took about 0.5% of the participants gave their care a perfect rating in our study. When we considered sex, race, religion, primary language, education, income, and depression symptoms, out of all of these, the ones that made sense is that primary language, patients that only spoke Spanish were about 50% less likely to rate their care as perfect compared to their English-only speaking individuals. So that says a lot, and hopefully we'll highlight more additional avenues that could then address what to do in these certain situations and how to best interpret monolinguistic Spanish speakers and their needs. Some of the challenges that we face as a study is, of course, the non-medical drivers of health that I've previously mentioned. Some of the families or patients do not have time for a study, for example. Why? Because they're the sole provider in their household. They're the ones working, they're maintaining, putting food on the table. So we've come into the discrepancies of potentially going to their home and doing the questionnaires at their houses in order to make them feel more inclusive and that they too can participate in the study. Dependence on transportation. Our team offers Lyft Concierge, where we pick the patient up from their home, come to the institute, we do the questionnaires, and then drop them off at their home at no cost to them whatsoever. Some have health-related issues and comorbidities, so lung cancer patients have to take more breaks because of the amount of talking that is involved with these interviews. We take that into account, but many of them are still wary and are cautious of their abilities to do so as well. Privacy concerns were mentioned earlier, and so that's something that we take into account with our participants in this study. And then emotional sensitivity. Sometimes our questionnaires can be kind of sensitive in nature, but we always advise our patients they're not required to answer any questions they do not feel comfortable in speaking about. And so what do we do with all this information? What is even the point of this study, right? And so this is to inform and create a guide. Again, what interventions, what practices, what treatments in the future can we address by looking at the trajectories in our study? How do we impact our health drivers in Hispanic Latino cancer survivors? How do we take their psychosocial answers and translate them into more clinical management, more prevention, more education to individuals in rural and urban areas? These are some of the powerful participant quotes that are given by our current participants in the study. These show the personal and emotional impact overall of being part of our study, and they ultimately are co-creating this knowledge, right, that we're learning on a day-by-day basis and shaping future healthcare. One of them is, for example, for the longest time, I've asked God why I was diagnosed with cancer. Now I feel I have a purpose to share my story and help others have a better experience than I have, which is what we are striving and what our goal is for this study. Of course, this is me shamelessly plugging our study. So if you or you know somebody that is a cancer survivor, we will be recruiting participants within the next 3 years for enrollment. So now shifting gears, I would like to add on our Avanzando Salud Center. This center is our health equity center at UT Health San Antonio. This is directed by Dr. Amelie Ramirez, again, the same individual from the Avanzando Camino study. And with this, we are striving to understand and ultimately improve research, reduce health burden across the cancer care continuum in South Texas with community engaged research, training, patient assessments, and promotion that addresses non-medical drivers of health. And so what we do is we fund scholars, for example, at UT Health, Incarnate Word, or anywhere that's interested in learning more about how do I apply non-medical drivers into my research studies. So we've had scholars that tackle issues on HPV, breast cancer, colorectal cancer, you name it. We also develop tools that integrate a screener, non-medical driver screener, into Epic, which is basically our database where we house all of our patient information in clinics and hospitals in order to promote a system level change. We also ultimately create a comprehensive screener that addresses and capture financial stressors, social, environmental risks, for example. This is now being integrated currently at Mays Cancer Center, and soon will be integrated hopefully across clinics in South Texas to help connect patients with resources in real time. And with the help of patient navigators, we can, our center seeks to ensure our patients are screened for non-medical drivers of health in order to prevent cancer early on. We also leverage our Salud America network in order to share information and inspire advocacy. So these social media policy campaigns are something that we aim to share with our communities in order to demand health equity. So what can you do? That's the big question, right? We invite everyone here to use our tool and spread awareness, and also to advocate for non-medical drivers of health screening at your institutions or your organizations. It's basically a 3-step action pack that has FAQs, case studies, conversation starters. They have emails, checklists, sheets that develop screening tactics that will guide on the existing screening tools that we have at our Mays Cancer Center. So this is for anyone, whether you're a healthcare worker, a mother, a father, whether you're an educator or a teacher at an elementary school. This is something that you can download onto your phone and ultimately seek any opportunities and information involving non-medical drivers of health, not just in Bexar County, but for anywhere in the nation. So even if you have friends and family in other areas in the country, they'll be able to learn more about their areas. And so this data tool will generate a health report card, and network members can auto-generate local health data, access to healthy foods, places to play, healthcare providers, as well as geographical areas where poverty and lack of education are displayed. So if you're a researcher or know somebody that's looking to tackle some of these same instances, this is a perfect place to start. We have already over 20,000 individuals that have used a report card to get the data. So you can even share this with your elected officials to get information on your grants even, or just locally share with your family as well. And last but not least, we have our biannual conference called Advancing the Science of Cancer in Latinos. And this unites researchers, physicians, healthcare professionals, patient advocates, students, you name it. We basically have an attendance about 10,000, over 10,000 people biannually. And the proceedings for the book can be shown here in the link below. The next save the date is for February 18th through the 20th in 2026. So if you're looking to learn more about the area, it'll be here in San Antonio. And feel free to drop an inquiry form using the form. I would like to thank, first and foremost, special thanks to our cancer survivors and patients for being very open and honest and very brave about their survivorship journey. To my team, our collaborators for working on the grants and the research in itself. To the Socially Responsible Investment Coalition for having me here and for you all listening tonight, this evening. Thank you very much.
Hi, how are we all doing? Great. So I hate a podium. I feel very restricted. But before I start this, I'm going to say Anna mentioned a few of the health equity proposals whenever question time rolls around. If y'all have questions, I worked on a lot of them. I'm happy to talk about Johnson & Johnson, Amazon. Don't worry, we're going to get into United Health in this particular presentation. But any of the other ones, I'm happy to discuss as well because there's some doozies. So vertical integration in healthcare. Again, I'm Lydia Kuykendall with Mercy Investment Services, member of SRIC, as well as ICCR and several other socially responsible investment coalitions. Who knows what this is? Does anybody know what this really, really busy chart is? So this, for those of you that don't know, is what choice looks like in America, and that it's a big fat lie. When you go to the grocery store, you probably can't see the little labels. I can barely see the little logos, but they all lead to these 10 companies. And honestly, there's fewer than this now. Some of them don't exist anymore. But when you're buying a kind of candy, you think, well, I've got 50 choices from what company I buy. No, you don't. You have maybe 2. They're all owned by the same. And I show you this chart because this is where we are or will very shortly be in healthcare as well. And it's a really impressive marketing job and regulatory job on behalf of these companies that people don't necessarily understand that this is what's going on. The illusion of choice is what's important to the economy currently. And we kind of hope that that doesn't continue to happen in healthcare, but that seems to be where we're going. So we're going to start with a big scary number because it's an important big scary number. $4.5 trillion is what we're spending, which is over 17% of our GDP. And that's only getting bigger. Our country is getting older. Our population is increasing. We're getting better at diagnosing things, which is great. It means we find things earlier, but there are more things to treat. And so treatment is getting more expensive. And everybody's sort of looking at AI as a possible savior. And there will be some good things AI does. But in the meantime, there's a lot of bad things AI is doing. So everybody's fighting over the best ways to implement this. Meanwhile, Americans keep dying of highly preventable and treatable diseases. So how do we try to roll that back, or how are we trying to change the narrative and change the trajectory? And the answer is we're doing a really bad job at it right now. And what we really need is more corporate help and less corporate obstruction. These next 2 charts are just going to kind of show you that it's not, I mean, you already know, but I like charts. So this is what other countries spend on percentage of GDP. And you'll see us up there with Liberia and percentage of GDP. And you don't have to go down very far to see some of the high income nations. So Japan, Switzerland, but the numbers are vastly different. We're spending 17%, they're spending like 10 or 11%. And when you think about that in numbers of billions or trillions of dollars, it's a huge difference. That's money you can be spending on almost literally anything else. And this is what we're getting for that $4.5 trillion is dead last out of all of these 10 countries. And I think pretty much every category. And again, I think this is something that a lot of people understand or know, but maybe don't really understand the implications of. And that it would be one thing if we spent all this money and we ceded all of our power to corporate entities in order to be the best in the world at it, but we don't. It's quite the opposite, actually, especially among high income nations. We're among the bottom of the barrel in nearly every category. So what exactly are we paying for? What does anybody, what do y'all think? What are we paying for? Well, we are definitely paying for advertising. We are paying we're paying for advertising for more profits. Exactly correct. So what, and that we're okay, we were going to get to this eventually. What is vertical integration? So vertical integration, that title would sort of predicate that there is something called horizontal integration, correct? So horizontal integration is probably what a lot of people in this room understand as like mergers and acquisitions. So if Johnson & Johnson bought and took over Pfizer, for instance, that would be horizontal integration. That's one company in the same industry taking over another company in the same industry. Vertical integration is a similar type of merger and acquisition, but up the chain instead of across it. And there, don't worry, I have a visual aid for this as well. So it's mergers across the healthcare supply chain. So again, within the same supply chain, not across it. Trend, lots of it. The trend is big. So there's a lot of different kinds of vertical integration. Commonly, you can have an insurance company taking over a PBM. You can have a hospital system taking over a physician's group. You can have a hospital system taking over a physician's group, taking over a PBM, and now all of a sudden you've got a one-stop shop, so to speak. And that is what we've got on this handy dandy visual aid. So this is sort of the big players in the insurance industry in this country. And you can see Blue Cross Blue Shield, Cigna, CVS, Elevance. Did y'all know that CVS owns Aetna? A lot of people don't. Humana now owns a lot. United Health Group, again, we've got like 3 or 4 slides on them by themselves because they're a thing. But this is all to point out that harkens back to the very first slide. Your choice is probably a lie. So not only is either the government picking your physician, but your physician is being picked by their insurance companies, being picked by the hospital system, and you're just kind of stuck where you are. So fewer hospitals are independent of health systems. Now, there have always been large health systems in this country, and in a lot of ways, that's not a bad thing. The pretty precipitous uptick in the dwindling of independent hospital systems is being seen as problematic just because, well, we'll get into those reasons later. This is more just to say that, 25 years ago, it was about half. Now we're inching up to 70%. So it's getting very, very hard to find a hospital that isn't part of a large system. And that's true with physicians as well. And that's what this chart is showing, not just hospital systems, but now we're getting close to half of physicians are now working for these large sort of behemoths of corporations, or as I'm going to look at very briefly in the next slide, private equity. So why? Why are we marching towards this world where everybody goes to the same provider? And honestly, when you think about it again, they're very good. It's a very good marketing ploy. And they'll say, think about healthcare in this country. Does anybody like their healthcare? No, maybe one person could. Yay. I don't. Most people, if you ask most Americans, the system is incredibly frustrating. It is fractured. It is siloed. You have to talk to this person to get this done and this person to get that done, and then go back to the first person and then find a 5th person somewhere over here. So when you're talking about integration in healthcare, whether it's vertical or horizontal, but especially vertical integration, they'll say it's all the same system. So it'll be much easier to talk to each other. The electronic health record will be able to talk to your insurance company, we'll be able to talk to the PBM, we'll be able to talk to your physician. It'll be seamless. And that's a really appealing thought. I mean, I would like to talk to fewer people about why I think I should have really basic healthcare. But unfortunately, we now have probably a decade or so of research, if not more, that says there is no real efficiency or cost savings. What there is a decrease in quality of care. And that last point is a little less certain. What is fairly certain at this point is that vertical integration does not save anybody any money and does not increase access for just about anyone, despite the promises. And these are the people that are sort of leading the charge in this. And I'm not going to talk much about PE, private equity. That's a whole other animal, really. And it's certainly worthy of being discussed, but would be a whole thing. Very briefly, private equity is exactly what it sounds like for those of you that don't know. They buy up hospitals or hospital systems, and they finance it with an incredible amount of debt. So they borrow enormous amounts of money, and that debt then gets passed on to the hospitals who are saddled with debt, and they have to cut corners in order to pay off that debt. But that's a whole other thing. The corporate consolidation is sort of what we're going to talk about more today, which is what those two charts were, with the vertical integration around like Cigna and Aetna, Humana, and then the mergers of hospital systems. That's what those are the corporations that are really looking to sort of expand their reach and grow and grow and grow to acquire more and more of these companies so that they can provide more and more services and make more and more money. Okay, so there's gonna be a decent amount of repetition because there's several things I want you to remember. And this slide is one of them, rising costs. And I'm gonna say it a lot. One thing we're sure vertical integration does is make things more expensive. And it does that in a few ways, and we'll talk about a few of those ways. There is an important distinction between in and outpatient care. If you get a procedure done in a hospital, it's more expensive than if you get it done somewhere else. I think everybody probably knows that. And in a system that is vertically integrated, they are going to have reasons, mostly financial reasons, to refer you to the hospital within their system to take care of this procedure. The referral system becomes very pointed and very preferential towards the system that you're in. Whether that's the best for you as a patient or not is not really that important. It's whether or not it makes sense for the system in which you are currently operating. Brown University recently came out with a study that said all physicians in the US were to fully integrate, it would lead to more than $350 million in just Medicare spending. This is just Medicare spending, and more than $63 million in increased costs for patients for just 2 procedures. This was related to colonoscopies. And I put this up there specifically for the Medicare spending part, because if you go back to the very first slide, the $4.5 trillion, companies like United Health, who is the biggest Medicare Advantage insurer, noticed that $4.5 trillion and they wanted more of that pie. So they said, you know what? If we can get more of that $4.5 trillion pie, we can also make them spend even more of it by referring to our own internal systems and programs so that we keep the profits at home. And that's what's been happening. And this is just an offshoot of that. When you have everything in one place, you can't go anywhere else. So the insurance networks get really small. Patients wait longer. You have fewer services. You're not putting the patient need first. You're putting the system need first. And doctors can find that system very frustrating. Insurers can find that system frustrating as well, if not very profitable. PBMs can also find it frustrating. But what they find it more than anything is easy. So that's what they do. Not just with Medicare billing, but private and commercial insurance as well. These are systems that I don't know if anybody do like any kind of electrical engineering or electricity background. The path of least resistance, current. We like shortcuts. That's what they're doing, right? It's the path of least resistance. They're going to take the easy path that will make them the most money because that's the point of their existence as a for-profit company. So that's what they do, and we shouldn't be surprised when that's what they do. So this is more of like market consolidation and monopoly issues, because, as I've mentioned several times and will continue mentioning, as these companies and corporations continue to integrate and merge, it's less choice and less freedom for us. The fewer insurance providers there are, the fewer choice we have. And that, I know that sounds so stupidly simple, but they will give themselves different logos and different slogans and different websites. So you think it's a different company when in reality, it's owned all by the same behemoth of a company or conglomerate. And this is played out a lot in the tech space lately, if y'all have paid attention to that. There's DOJ, Department of Justice, and Federal Trade Commission lawsuits against Google and Meta and others. And Google, very specifically, Alphabet, its parent company, suffered a loss this week. Where the court system said, yes, it is actually illegal that you have made your own product the default search engine on all products, and that Apple is paying you to do this. It is anti-choice. It is operating as a monopoly within a system that's supposed to be a free market economy. And that's very similar to what a lot of these healthcare companies are trying to do today. Now, whether it'll make it to the size of an Alphabet, United Health is getting pretty close, quite frankly, and we'll see if the FTC and DOJ do anything to rein them in. They're looking at it, as we will see. And again, this bottom one, the financial interests override clinical decisions. The patient is not the point. The system is the point. And I think, to the lack of surprise of everyone in this room, health equity is probably the first thing to suffer. And I don't like reading off of slides, but I'm going to read this one because I think it's important. While there were no average changes in adherence following vertical integration of PCPs, primary care providers, health equity worsened with significant declines in adherence for Black, Asian, Hispanic, and Native American patients, patients over 80, and patients with greater comorbidities. These findings suggest that integration may reduce clinicians' incentives to compete based on the quality of care delivered. And that's sort of the point of most of this presentation, is that when clinicians and providers don't really have a reason to try to do better, path of least resistance. They're not necessarily going to. A lot of doctors will do their best and they will fight their best for their patients against a machine, but the machine is usually going to win. And why are we making doctors fight these fights anyway? DOJ and FTC are increasing their oversight, hopefully, of these processes. This is actually really interesting. In March of, and I had never seen this before. That does not mean it didn't happen. But in March of 2024, 3 federal agencies got together, the FTC, the DOJ, and HHS, Health and Human Services, to have a request for information about consolidation of healthcare markets, about this exact thing. And one thing the Biden administration did on its way out was release the results of that request for information. And this paragraph is one of the conclusions. And it's pretty stark and straightforward. And it's what I think all of us who have been listening to me ramble on for 15 minutes would have guessed, that when you consolidate in this way, you've reduced access and increased cost. Case study. Oh, we're on a United Health Group. Okay. So United Health Group owns a bank. They own a PBM. They're an insurer. They own more physicians than anyone else in the United States. They are, those neighborhoods that kind of look like it came out of a TV show because it's got a little bank and a grocery store, and you don't really ever have to leave that little neighborhood. That's what United Health Group is right now. Basically, you never have to leave the cozy little space of United Health Group's Optum offerings. And what that has done is a lot of concerns around monopolies and data misuse. There's been, I don't have to tell you how often United Health Group has been in the news, and not just because of the murder of one of their CEOs, but because of data breaches, lawsuits, other reputational risks, which I think we've got here. And it's interesting doing this kind of work, because a lot of times when you talk to a company, they'll say, well, maybe this is a problem for some of our peers in this industry, but it's not a problem for us. Why are you picking on us? And United Health Group can't really use that argument because it's clearly them that's the problem. And this is the resolution that we submitted to them this year. Now, it's an interesting resolution because you'll see it doesn't say anything about vertical integration in healthcare, because United Health Group has so many problems that frankly picking one was going to be difficult. So this year, the coalition of investors that work on this company decided to discuss them on a systemic level. So this is talking about systemic macroeconomic risks, which is just a big way of saying you're ruining the economy. This one company has so much influence on this country because healthcare is such a big expenditure for every American family. And we think you influence the market so much that you single-handedly are contributing to depressing everybody else's diversified portfolios. They hated that argument, unsurprisingly. We ended up having to withdraw it because the current SEC also would have hated that argument. But I still think it's a really important issue to raise, and not just with United Health Group, with some like companies like an Amazon or an Alphabet that are so big they're ruining the world. I think putting it in the mind of other investors, saying we understand that usually when you look at your portfolio, you're looking at the risks of an individual company. What is this individual's company's actions? How are they hurting that company's performance? But that's not how most people's portfolios work anymore. We're all diversified investors. Nobody only owns one company. Everybody owns a little bit of everybody for the most part. So what United Health Group is doing is messing up what the rest of your portfolio is doing. If the whole world is sick and can't go to work because they can't access health coverage, then that's going to depress the value of everyone's portfolios. Now, that's obviously the business case and not the very simple ethical case of maybe we should worry more about patients than profits. But unfortunately, in the financial world, sometimes you have to do both. This is from People's Action Care Over Cost campaign. We worked with them on the United Health resolution. And these are three, I think, really easy, really interesting asks for companies like United Health Group, but also other companies in the healthcare space. So AI, it's saying, and look, every company will say they don't do that. They'll say, we don't deny using AI, but they do. And it's not a policy that's written, which is how they can say they don't do it, but they all do it. So just keep telling them over and over, you cannot bulk deny claims using artificial intelligence. There has to be a human at the end of this because there's a human at the beginning and that human needs a human at the end. Equity, again, we talked about this a little bit, but prior authorizations, claim denial processes, are you actually denying claims at a higher rate for people over 80 or Hispanic people or rural people? Do you have disparities in how you're processing these claims or using prior authorizations? Break it down by demographic and market and show us. If you're not, as United Health claims, if you don't have issues with claim denials, show us the money, so to speak. Give us the data. You have it. It would be so easy. Just publish it and we can all move on. And that's what transparency is. And that, as investors, is where we're really trying to make way with United Healthcare and a bunch of other healthcare companies. Is the conversations we always get into them is they'll say, well, everyone else is wrong. We'll come to them with a study or with a congressional hearing. They'll say there's this data XYZ from academics, from nonprofits, from whomever, and they'll say all that's wrong. Say, okay, great. Show us the data that shows that. And they go, no, you're just gonna have to trust us. And go, that's not how it works. So saying, if you talk to companies, say, I get that this is where you're coming from, but you can't, this isn't kindergarten. I'm gonna need like an actual show and tell situation. You're going to have to publish this data, make it publicly available for all of your stakeholders to see that this is how your business is running. Because if it's not, that's a material and salient risk to the company and thus the company's investors. So yeah, these are just asks from various stakeholders and investors big at the bottom. Again, disclosure and transparency. You'll notice we're not asking them to change anything. We're just asking them to be transparent about what they're actually doing. What is your business practice? Tell us what you're doing, and then we can decide as consumers and as investors if we want to use your products or invest in your business. But if you don't do that, we can't have an honest conversation about the kind of business you're really operating. Does all that make sense? Okay, great. And I think that's it for me. Maybe, yes. So, all right. See, there were only 3 things. This is all you got to remember. Increased costs reduces access. Competitive systems benefit all stakeholders. Can we do that? Monopoly is bad. Expensive, bad. Competition good. All right. Thanks, guys.
Good evening. I'm the caboose, as I was told when we were being brought up. So my name is Will Snyder. I'm excited to dive into a little more of a data-centric presentation, really focused on as an example of what we've heard from Derek and Lydia. So looking at a rural healthcare dynamic, especially with around behavioral health and mental health. And thank you for having me. It's exciting to be here. This is my very first time in San Antonio, all like 24 hours of it. I unfortunately have to go back to Chicago fairly early tomorrow morning. But in Chicago, like a lot of American cities, we ran some highways through in the 1950s and 60s, mostly through marginalized neighborhoods. But there's one part of one of the highways, the Kennedy Expressway, which you take from O'Hare to get to downtown Chicago. And it had to go around a convent and a chapel. And for many years, the sisters had a billboard up that said, "Our faith moved a highway. Think about what it could do for you." And so I bring that challenge back to you all. Given the current market dynamics in this country, your faith is going to get us through and hopefully get this thing stabilized. So I'm grateful for all of your work and service, especially the women religious here tonight. I have a very brief bio that's not particularly interesting in the program, but I will say what I'm proud of is I spent many years in journalism and then made the move to healthcare and health policy through Catholic healthcare. So I worked in the Bon Secours Mercy world, speaking of integration, and then also for a Catholic health system in the Chicago area. So I've spent a lot of time in this space and I'm very familiar with a lot of the work. See if we can make this remote control go. All right, there we go. Yeah, that's me. So Sister Patricia, you got the name right. So I started, I left the comfort of working on Medicaid and Medicare payment policy, which is, you know, really exciting, auxiliary work. It's very, very important, but very boring. As a professor of mine in grad school said, it's like chewing gravel. And so one of the roles that I had or had oversight for in the health system administration was protection of our tax exempt status. And that is a requirement that Catholic healthcare has done for over 50 years through something called the Community Benefit Inventory of Social Accountability, also CBISA. The Obama administration saw that and said, that's actually a pretty good way for nonprofit hospitals to justify their tax exempt status. They should go out, figure out what's wrong in the community or what the issues are, put a plan together, and then address that plan over the subsequent couple of years. And we'll use that, the investments and the effort they put into that as the measuring stick for their tax exempt protection. The problem, and you're probably hearing some threads tonight, one of the problems in healthcare is that everything is actually from the government, even if it doesn't, like, even if healthcare pretends to be free market, all payment all payment levels set on the provider side come from the Medicare cost registry. So private insurance adjusts based off that. Medicaid says Medicare is paying that. We're going to pay half of that or some other difference. The amount of money states get is for Medicaid, again, dictated by the government. The government then regulates everything you do inside of the hospital, which creates all these little fiefdoms, which I think Lydia is kind of touching on. So some people just say, well, the macro solution is to integrate everything. And then others say, well, no, maybe not. Maybe we should think about other ways. That, you know, maybe we should try to untangle each of these little fiefdoms and really think about how we make it a consumer-centric model. Anyway, this is all to say I was on a committee through the Catholic Health Association to advise the Internal Revenue Service, the governing agency of nonprofit status for hospitals, go figure, on what they should be measuring, how they should be thinking about doing this. In all of that, I recognized there was an opportunity to take this assessment process, essentially this population health equity assessment process, and actually make it useful in healthcare. At least that's the hypothesis. So I started a company to do that with two of my former employees. The name of our company is Metopio. This story finally came back to where I wanted it to start. So I apologize for the meandering. I have a grandfather who was a circuit riding lawyer and a grandfather who was a circuit riding Methodist minister, so I can talk. So anyway, we started this company called Metopio. Why Metopio? Back to the biography, I studied the classics in undergrad, and the only thing you could do with the classics is tell people you studied the classics in undergrad, or you can try to name your company after that. So we put together two Greek words, which really get to the essence of what we'll cover today, meta and topos. So meta really has a couple of definitions about or beyond or sort of context, and topos means place. So when we put those together, you get the name of our company, Metopio. We really try to help people, especially healthcare providers and policymakers, go beyond their traditional understanding of a place. And this is important because if you've not heard the statistic before, or this factoid, your DNA or your zip code is more predictive of your health outcomes on average than your DNA. So where you live, what options you have in your community, all those things drive the health outcomes that we see in this country. All right, so my company, what do? We collect lots and lots of data. We work very closely with our friends at Christus Health to do this. So we collect primary data through surveys, a bunch of other channels. We ingest lots of government data. Long may it live. We'll see what happens since you've probably seen some of this has been pulled down. We work with providers to get claims and utilization data. And then we're starting to dabble in the really interesting world around sensor data, search data, mobility data, those kinds of things. All of that goes into a data model that we built, which allows people to then analyze and understand that data and think about who they're serving and what the needs are beyond what they're seeing in a medical environment. You know, this is if you have friends over for dinner, you should never cook a recipe for the first time when you're having them over for dinner. I put some animations in this, and I sort of feel like that's sort of the same thing. We'll see if this works. So, you know, I think the important thing to remember about data is that these data represents real life experiences. And when we dissect those get down to an individual. And those don't have a tremendous amount of value on an individual level from a policy standpoint or from a change management standpoint. But when we aggregate hundreds of thousands of people or tens of thousands of data points, they become really powerful because we can identify these trends. And those trends can become policy recommendations and help us change behavior. All right, so we're going to talk about economic data first, then community data, and then see if we can mix it all together with a great example from Christus. Oh, this worked. So if you don't know how hospitals get paid, it's through 5 things or 6 things. This is non-academic, so Derek's working in an academic medical center, so they have a lot of grants. But generally, like a rural hospital, and to Lydia's point, like with vertical integration, you run the risk of losing choice. With rural, what we're seeing in America is you lose the option for care. It's purely binary. You have a hospital. I drove to Corpus Christi this morning. There are not a lot of hospitals between San Antonio and Corpus Christi. One goes away. You're just out of luck. And the problem with health behaviors is unless you have something where you can't function on a day-to-day basis, like insulin, you know, blood pressure medicine, cholesterol medicine, those kinds of things, what we see is a lot of times people are just like, well, I don't see it. I don't feel bad. You know, I'm not going to take it, or I'm going to choose to do something else. And then it becomes a major issue that you see in the emergency department. So anyway, we're talking about a binary choice in this presentation. So EDs, inpatient services, lab, radiology, medical supplies, and some sort of outpatient services. That's how you make money, or that's how you get paid. So who pays you? In rural healthcare, it's a very limited payment stream. Health insurance plans, as we hear, sometimes they pay, sometimes they don't. Those are both government and non-government. Any delta that is left is the obligation of the patient. If you're an uninsured patient, which we see quite a few of in rural areas, in part because of stigma and also because of employment options, it's on them. Government funding, but not necessarily grants. In this case, it's special, kind of a classic political maneuver. When we upset rural areas, we figure out some way to create a federal appropriation for them. And in this case, we see that with a lot of like rural carve-outs in terms of healthcare spending. They're specific, which are critical to keep the hospitals open, but you know, you'll see like we're not paying for this except for certain rural hospitals. In addition, a lot of rural hospitals have their own taxing authority. There's some authority that can tax in the county or state to provide that supplemental funding. And then the ever lucrative cafeteria, gift shop, and parking lots at hospitals can also contribute some revenue. But the problem is that it's just not enough. So almost 20% of rural hospitals had losses greater than 5% last year. And in healthcare, you get really excited if your margin is like 0.5% positive. We're not talking about huge margins with especially with nonprofit hospitals. And then when we get into what is one of the most critical needs in our country, you really lose a lot of money. So that it's a negative margin of 34% across all payers for inpatient psych and behavioral health. And then it becomes really acute even among government payers. So Medicare, Medicaid are not paying what it costs to operate those services. Yeah, and then outpatient behavioral is also on a really bad margin. So this one, I apologize. I like the colors, but it's small. It's small and hard to read. But on the left, what you see is the contribution to margin by different revenue sources for rural hospitals that closed between 2020 and 2024. And on the right, contributions to margins for ones that stayed open. And what you'll see is they just lose money from pretty much all payers. So the only thing keeping them relatively functional is that taxing authority or government funding. So when you're running on these razor thin margins in rural areas with very small populations, it's really hard to do. And so it's really hard to offer the services that are needed. I'm going to talk about Texas tonight. I know we've got people from other states, including myself, but I like maps, and the Texas state is a pretty good map, makes a really good map. Texas is number one in the country in a lot of things, but this is not a good one. Number one in the nation for mental health provider shortages. So this means there are not enough providers for need. And that actually equates to there are about 14.8 million people in Texas that can't get access to mental health providers. And I bet you can guess where I'm going with this. It's a lot worse in rural areas than it is in the urban centers. And then kind of on the flip side, Texas is towards the bottom for mental health providers per capita. And what you see on the map here, the darker areas are where those doctors and providers are located. And those are not rural areas. I can see where we are in San Antonio and the Braunfels in Austin. Looks really good. And then you do the route that I did today down to Corpus Christi, and there's not much of anything. So this happens, on this for a second, this happens for a variety of reasons. And I think one of the issues in healthcare, trying to think of analogies because I like them, even if they're not great or helpful, but this one I think is, which is, a few hundred years ago, there was some debate about what the center of our universe was. Was it Earth? Was it the sun? Was it heaven? Was it God? But, what was it? There was a lot of debate. And in healthcare, I would argue, we don't know what the center of the universe is, and it's a really obvious answer. It should be the patient, but it's not. The patient's sort of Pluto, maybe on a good day in Neptune. Is Pluto even still a planet? Which actually would really make it the patient. But, you as a patient don't matter in all these fights. What Lydia's talking about, it's between the insurer or the government and the provider debating price for the procedure that you need to stay healthy or alive. And if you have those incentives out of whack, what we miss are a lot of the social determinants or the non-medical drivers that Derek spoke of, which is what we'll get into in a second, which is really what's driving ultimately the cost. It's delayed care, inability to get to care, and so forth. So for this all to work, we really have to, give Galileo his due and say the center of the universe is the patient. And how do we put the system in place, social care, healthcare, and everything else, and orbit around the person? And that's where we really get to this idea of whole person care. And I also think if we can do that, we can push down the cost, but now I'm editorial. And the other piece there, I think that is hard for healthcare and insurers is if the patient's at the center, they're not. And that's, everybody likes to be the top dog. But the most important thing we can do here is collect data, gather these community voices, which will then help hopefully illustrate and drive better policy. And I, again, just want to call out Christus. I think they're one of the national leaders in how they're thinking about collecting data and using that data across their enterprise, but also through their advocacy work and through their programmatic work. So in the last year, we've gotten about 20,000 survey responses in the Texas Arkansas, Louisiana area for a couple of different clients, all asking a similar question. What do you perceive to be the most challenging issues in your community? So I'm going to do this like, Vanna White, do the big reveal here. Mental health, no surprise. That's the number one issue. Everybody says in every survey, mental health. We were getting it so much that we said we should probably stratify this more and say, adult mental health, adolescent mental health, substance use disorder. It's all, it all rolls up. It's still, we're seeing that, if we have that stratification option in the surveys, we see adult mental health, adolescent mental health, substance use, then the other stuff. Then it's chronic disease. But really with chronic disease, it's three. It's diabetes, heart disease, and obesity. Or as a medical professor at University of Chicago told me a few weeks ago, well, I just call it diabesity now. Because you're going to see it again in clinical settings, you just see it together all the time. And she said, that's just how I start to think about it and refer to it. But it's mental health followed by heart disease, diabetes, and obesity. But then housing, affordable housing, safe housing, high quality housing. Transportation. I can't get somewhere. I don't have a car. There's no public transportation. And then lastly, medication affordability. So across 20,000 survey responses, this is what we get when we ask people, what are the big issues that you face or your community faces? And they're not talking about any of the other stuff that we've been talking about. Yes, so here's how we kind of build on this. This is not equal to CISO, which means not a single input, single output analysis. So community context and comorbidities or disease, they coexist and they have to be understood together. And this is a great way, great way to do it minus my head floating around the far end of the scatter plot. But maybe I could actually be one of the bubbles in the scatter plot. So what you see here are Texas counties. Each bubble is a county. On our x-axis, we see the hardship index. And we want to understand the impact that the hardship index, which is a roll-up score of socioeconomic burdens. So the higher the hardship score, the harder a person or a community has to access food, access jobs, affordable housing, these kinds of things. And then we want to understand the impact that has on reported mental health. And what we see here is a highly significant, we've got a researcher here, so we can call it out. So the p-value is less than 0.0001. It's a very highly significant relationship. What is, to me, as a economist or faux economist, that I find really interesting in here is the size of the bubbles is actually tied to population density of the counties. So but as we go further up this trend line, what we're seeing is less and less population density. These are more and more rural counties. So you're seeing high hardship and high rates of mental health. And this gets into that multidimensional reality that people live in. Not where am I going to go get my health care today? And so this is it. Like, we can't study these diseases in isolation. So, we know we've got people that have poor points of access. We also know when we get back to our revenue slide for rural healthcare or rural hospitals, that uninsured patients have to pay the full freight. Unfortunately, Texas ranks #1 in uninsured rates, and it's not a Medicaid expansion state. So you've got a lot of people that are having to carry that cost burden. And are they equipped to pay for that? And if they're not, you're now adding an additional stressor into their life or potential financial burden. So these are some maps, because again, I love maps. These are what we do in our software. You can make maps too in our software if you'd like. Here we see a map that shows the upper 50% of high mental health or self-reported mental health, poor mental health, and the lowest half for income. And that looks awfully rural in Texas, if I understand Texas well. A lot of West Texas actually doesn't even have reportable data because it's so sparsely populated, so we'll ignore that area out towards Marfa and Big Bend. And then we see the inverse when we look at low rates of poor mental health and higher incomes. So then you see your downtown San Antonio, the whole Austin stretch, Dallas, Fort Worth. So again, we could see this as we start to look at multiple variables together and better understand the context that our community members are living in. Another piece, like we've talked about earlier, so our clients or our patients are filling out our survey and they're telling us transportation's a problem. And people say, well, we're not going to run public transit. We're not going to do this, that, and the other. This is the transportation burden index on the map. Let me see, here we go. So transportation burden or mental health. My God, we just like keep coming back to the same things. People told us in the survey, mental health, chronic disease, affordability of housing, transportation, and medication. And we've not designed a system around that. We've designed a system around you come to the emergency department, we treat you, you give us a lot of money, and then we go and we haggle with our vertically integrated insurance company and all the rest. And so there's this huge disconnect where we have not put the person at the center of the work that we're doing. Not me, but the system writ large. So this is kind of what we have to start thinking about. How do we start to address these issues? And I'll stop on the data piece just by talking about social isolation. My wife's a clinical psychologist, and she likes me to bring this up whenever I can, because we do have an aging population in this country. And when we think about social isolation, we see that very much in rural areas, more so than urban areas. We've seen it obviously go up quite a bit since COVID, but you also see it, what you see here on the right is a map that's filtered for the top 50% for social isolation, or zip codes for social isolation, and then age of residence. So you're seeing both seniors and places with high social isolation in the map on the right, which again starts to look very similar to the maps that we saw earlier. And when people have to make choices, they live alone, they become a higher cost risk for the system. When they live alone, they're obviously also at risk for just the downsides of isolation, both physical and mental. And then if you have to factor in all these other cost pressures of transportation, medication, and so forth, it really becomes hard. But I don't want to be a pessimist. I think there's a lot of great work happening. And I think what's exciting, especially as you all sit here as advocates, not only for market-based companies and market-based solutions, but also for what the government can do and how the government can think about its policies and what it does. I'm going to call out what Christus is doing and really using this framework called impact, which is about informed, measurable 3 Ps, programs, partnerships, and policies that advance community transformation. And the 3 Ps become really important because they're nested in one another. Sometimes you just need a ride to the doctor. Sometimes you need somebody to give you a ride to the doctor or somebody to help you with that. And other times you need the city or the state not to build a 12-lane highway across your driveway so that you can get to wherever you're going. So there are these multiple levels. And this is kind of how you can start thinking about these the connectivity between these different domains. You know, health, so there's food insecurity, but if you live in a neighborhood that doesn't have any optionality for food, I like this term food swamp. I've not heard that one before. Usually it's food deserts. If you don't have a place for people to make healthy choices because they've redlined the community or they've zoned it in a way that you can't have grocery stores, all these things that become policy, this becomes impediments to being able to live a healthy lifestyle in certain communities in our country. That can then lead to places being unsafe. That can also lead to dilapidated or poor housing, which can also affect where cities allocate their resources to put parks or put green space. So all of this becomes related through programs, through partnerships, through policies. And so you have to attack each one if you really want to get to solving these upstream conditions that we see in healthcare. This is a great kind of walkthrough of what Christus has done in terms of how they diversify their data collection and then moved it through a whole process of approvals. This is very wonky, and I'm not going to speak to this slide other than to say this is actually really important work to do, because in Epic and in a couple of other EMRs up until recently, Hispanic was not a race or ethnicity. And so you would ask a health system, how many Hispanic patients do you have? And they wouldn't be able to give you an answer. And it's really hard to do Derek's research and the other research around differences in outcomes and so forth if you can't collect the data the way that people are telling you the data, telling you about themselves. And so Christus did a great job of aligning their clinical data with how they were surveying data or surveying in the community, which helps them then link those data sets. I will not speak to this, but they did a really smart system where they essentially looked at emergency data, who was coming to the emergency department, what were preventable conditions, especially focused on heart failure, heart disease, where were people coming from in the community, and then they created a score, a community needs score, essentially a needs index that they applied to zip codes, which is where they would then drive their investment through their community benefit funds to solve that partnership problem that we spoke about. And this got into this framework that they created is what they call communities of focus. And ultimately what it's about is reducing the life expectancy gaps that you see when you start to look at different socioeconomic or racial and ethnic stratifications in neighborhoods. And then you have three components they use here. So anchor mission, which I'm sure many of you are familiar with, but Christus and a number of Catholic health systems are actually national leaders in this space. So thinking about how they put their resources into community businesses, hiring practices, and so forth. The clinical piece, so how are they collecting that data? How are they thinking about upstream solutions? So if somebody is flagged from a community of need in their EMR, can they get them wraparound services and so forth? And then ultimately the partnerships that drive the outcome. So this transportation was an issue. So this is down in Corpus Christi. They created a mobility options program, which is based on a scientifically proven partner or program, or evidence-based program, I should say, that help people with disabilities of all ages, and then seniors and low-income individuals access transportation to get to not only medical appointments, but I believe also additional, like the problem is they could get to the hospital and then the doctor says, well, you need insulin, you need heart disease medicine, and you got to go get a blood pressure cuff, and that's at Walgreens. And then the doctor leaves the room, and then the patient's like, well, the service that I'm provided with PACE only gets me here, doesn't get me then to Walgreens, and now we're stuck. And so that, again, if we put the patient at the center of the universe, we're going to solve a lot of these problems, and they're going to be really interesting market-based solutions that can do this. And I think Christus has done a great job here. And really, this is it. It's like, we got to remove the complexity. We got to break down the fiefdoms. We've got to encourage a highly regulated environment to look at those regulations holistically, and not just this is one procedure, this is another procedure, and you've got bureaucrats focused on each one of those funnels. We really need to think about this holistically. And then communities, ultimately, they know what they want and they know how to solve these problems, and we have to give them the resources to be able to do that. Thank you.
Thank you, Derek, Lydia, and Will, for your insights, giving us lots to think about. Now I will open it up for questions.
I've got a mic. So I'll bring you the mic. Anybody?
So just to start the conversation, thank you for your talks. They're very, very interesting, informative. I know there are lots of questions, but how about the access to, how does it work? It really works? Access to virtual doctor's visits. Like, is it really working? Do you have any information? And I have a second one. I think when it goes related to also hospitals are integrating virtual doctor's visits as a part of their services. I don't know if it is really working. And the other one is, we get all these surveys after the doctor's visit, and I always wonder who gets those, like who really hears my what I saying.
I can speak a little bit to the virtual piece. So again, that's one that, especially during COVID, back to the regulatory behemoth that is Health and Human Services, they waived a lot of restrictions around reimbursement for telemedicine, and we saw a huge uptick in usage. They've now rescinded or pulled back a lot of those payments. Started under Biden, and I suspect the current administration will probably continue to tweak those changes. It's disappointing. I think it's a great access point. I think, but back to the rural issue, then you have to figure out internet and smartphone access or some sort of digital access. I think where there's more promise and probably more focus right now is on wearables and or what are called wearables. So, you know, heart monitor, like, you know, other things you can wear on your body that feed into some system that then allow your medical team to be able to track progress or what's happening. But that space is where people, I think, have tried to disrupt healthcare delivery with mixed results. Because again, it gets back to Medicare sets the payment rates for everything, and including the private insurance market. And so you end up inadvertently creating a disparity because the people that can pay for it out of pocket do, and those who can't are left without the service. I'm very pro telehealth. I mean, we need to do as much as we can. And, you know, the whole process of healthcare engagement, like, you know, I changed my plane ticket and rented a car and did all of this stuff on my phone without talking to a human being. It was seamless and easy. There was no problem. And you try to do that with healthcare, and it's like you just run into walls. So there's just a lot of opportunity. And I'm sorry, I forgot your third question. Who gets the? Oh, good question. We might be able to send you a link. It's a randomized distribution, but you know, we also a lot of our partners like Christus, I think, really tries to over-index or over-survey and underserved areas. So they use their community needs score that we spoke about to identify those zip codes, and then they find partners like FQHCs, schools, homeless shelters, and focus distribution and those channels as well. But thank you.
Questions, other questions?
Hi, this is for Will again. I was thinking of the first few slides, which dealt with the loss, monetary loss in rural hospital. Can you speak just a little bit more about how you see the factors, how those factors could be reversed, and which factors they are that could be changed so that there isn't a 34% loss or 5%, you know, yeah, just clarify that a bit more.
It's a great question, and I don't have a totally direct answer. I'm actually curious what Lydia would say on the M&A side, so I'll turn to her in a second. But I think Texas has been at the vanguard for a lot of closures of independent freestanding rural hospitals, but also at the forefront for ones that have survived and figured out ways to work. What you often see, though, is that you have to build some sort of network adequacy or partnerships to address the specialist issue. So what we see in low-income urban areas and rural areas in America is that the need for specialty care is quite high, but the access to specialists is very, very low. And so when I was in Corpus Christi today, they were talking about having to send people to Houston, and there was an 18-month wait list for if you're uninsured or you're on Medicaid. So you've got to figure out ways, and this gets to the previous question on the virtual piece. So an area that is very common now is you know, you don't want to have a stroke, but if you have a stroke in America, chances are you're going to get connected virtually to a neurologist no matter where you are, because they built out a massive telestroke network across our country. And so that's where, like, if you're in a rural hospital, you'd want to be connected to Derek's hospital through at least some specialty care. And then you can reduce your overhead costs within your bricks and mortar where you are. And then I think it's also about how you program the hospital, what you're trying to focus on. But the issues that you run into is that where you see the needs, behavioral health, chronic disease management, those kinds of things, are not necessarily where payment streams are coming for those hospitals. And you know, I'm based in Illinois or based in Chicago, and our state has a lot of like specialty payment streams specifically for rural hospitals, and they're not necessarily tied to metrics that you as a patient would care about. It's more like, can you just keep your doors open, you know, and do this, this, and this on the scorecard? Then you get these supplemental payments from either the state or the federal government to sustain it. But that's not necessarily like a working solution based on what the community needs are. But I'm kind of curious.
Well, so, I mean, I'm just going to agree with what you said, which is, I think, and I am not a health economist. What I have seen is that we've got this literal Frankenstein of payment systems for rural hospitals, like dish payments, FQHCs. What I mean, then they all go away, and sometimes they're here and sometimes they're not. It's incredibly unpredictable based on what state you're in, whether your governor likes you or hates you, and whether the government likes the federal government. And it's all very political and very confusing and impossible to plan for, especially if you're a small system. And I think that's one of the things that makes these hospitals really attractive to like private equity to buy up, or to some corporations to buy up. And it would be really hard, I think, as a small rural hospital to not be really interested in that offer, because they've got a lot of money and they're saying, where are you going to save your patient population? At the end of the day, we haven't seen that play out very often in a way that works for patients, just because that's, again, as I think all of us have said over and over, it's not a patient-centered system. So yeah, I think the very short, depressing answer is, I don't know that it can change in our current system. I think these individual streams that Will was talking about have to stay, because it's the only way to keep them open. But the only way to sustainably keep them open and functional is to change the system.
I have a simple question. In Bear County,
Okay, I'll answer this one.
in Bear County, like we've got Christus, we have the Baptist hospital system, Methodist hospital system. Who owns Christus? Who owns the Baptist system, and who owns Methodist system?
I have no idea.
Those are nonprofit. Well, East Baptist and Christus are nonprofit, faith-based nonprofit health systems. So Christus you have a public juridic person, I'm guessing. You have a PJP, public juridic person. No? Oh, you're the sponsor. Okay. So they have a sponsor. They're sponsored by Women Religious, the orders that set up Christus. And so you see that's sort of the common structure. They could speak to it better than I can. I don't know who owns or I don't know who sort of operates Baptist, but it would be a nonprofit board of directors. Oh, they are for profit. Wow, that's a tricky name. God. All right. Sorry, apologies. So yeah, if they're for profit, then they have a shareholder environment that they're operating in. It might be a limit, they're not publicly traded, most likely, but obviously was wrong on Baptist being nonprofit. But they have some sort of ownership structure where they are, required to pay dividends or pay out to some group. Sorry, I can't answer that more clearly.
So Baptist is owned by Tenant.
Okay,
a
yes, yeah. So
bigger
Tenant, yeah.
organization.
Yep. Yeah, that's one of the biggest. And
And I
the
think-
HCA and Tenant are sort of the two largest for-profit.
And Methodist is a nonprofit because they have a foundation, 50% of what they raise, but they're, I think, in university, is a utility part of the UHS.
Thought it was a simple question. But this is where Lydia's points about private equity getting into healthcare is you're just seeing more and more of it. And usually it's the physician level or the practice level. Like they'll come in and buy up a whole bunch of dental practices. And then what they do is consolidate the back office. They, cover the marketing costs, those kinds of things.
other questions?
I don't mean to monopolize it. There's someone. Lydia, take a, have, since the Luigi Mangione incident, have you seen, any changes in United Healthcare
No.
and an impact? I mean, in terms of transparency, I've read it, there's been protests and so on and so forth.
Yeah, so there, Andrew Whitty, the CEO, had some, I mean, what should have been important words to say about how the system is broken and they need to change, but they're not. My discussions with them were, we're again, we haven't asked them to change any part of their business. We have only asked them to disclose what they're actually doing. And they have shown zero interest in that. They have fought us every step of the way. And that hasn't changed in the last 6 months at all, is the short, sad answer to that.
No other burning questions? I think we'll go ahead and move to our closing. Anybody?
Thanks again to Lydia, Will, and to Derek. Okay, now Sister Susan Mika will bring the evening to a close. I'd ask everyone to get their little booklets out that we have on the table. And it's mainly to thank everyone for all the things that have happened tonight. And yes, our panel, I think each of you gave us more things to think about and to kind of expand our horizons to understand so much more about healthcare and all the things that are needed, and I mean, of course, we hear about all of this every day, it seems like, because there's so many cuts being proposed, especially around Medicare, Medicaid, and, they're talking about like some of the hospitals will close if there's not Medicaid, and of course, nursing homes, et cetera, with, the Medicaid dollars. So, wow. So again, thank you to our panelists, and I want us to look at the back page. I know we've thanked already some of the groups that have been sponsoring us, but on the back page of our pamphlet tonight, it's so expansive in the sense of like all the different event sponsors. So again, thank you to all of those that were able to sponsor our event tonight. And they have the founding members of SRIC. We were talking about that. Our SRIC board officers, Sister Patricia, Sister me, and Esther, who's very important on our board as well. And I want to just talk a little bit about the last part there, the institutional members, the associate members, and the individual members. Our coalition, SRIC, is more like ICCR, our national group, than many of the other CRI groups, because we have these various levels of participation that some of the groups, they only have like institutional members. And so we're very, very fortunate that over all these years, we've had this kind of a breakdown where we have our institutional members, the associate members, and you see there some of the groups that are our investment advisors, as well as Mercy Investment Services and a union, Texas AFL-CIO. And then individual members. So again, if you know of any other individuals that might want to join our work here at SRIC, let Anna and Ruben know, because we'd be very happy to have them become members and, get the updates and get the reports and all that our members do get. And so I also just want to thank especially our caterers. They've kind of cleaned up a little bit here already, but Nydia Morgan and her staff, and now they've changed their name. It's ADC, but it's still Absolutely Delicious Catering, and we've had them for many years.
And and then we also wanted to thank Oblate School of Theology for their staff that have been helping us here at the Whitley. Zinnia Rocha, Ruben Benavides, Gavin Harrison, they help us make all of this work. And our volunteers that have helped us, Nina Martinez, Laura Waldron, Esther, thank you again for buying the award that we gave out tonight. And Robert McKinley for being our photographer. Thank you so much. And of course, we want to thank our staff, Anna and Ruben. Y'all can wave in the back there. We all know that it takes a village to put this together, and we're very, very grateful for all of your work. And I just wanted to, people were bringing up like, when did SRIC start and all of that. And, I think we mentioned before that in 1981, there were all those meetings. So technically we started it in 1981, and some of your treasurers were the ones that went around all around Texas to try to get us started after, so many years of Sister Frances Lorene keeping in her heart, from 1974-ish to 1981, that we should have this group. And then we actually started in 1982. We count that as our starting. And I would just remembering that group that was the executive committee at that time, Father Tom Byrne, he was a Spiritan, Father Rufus Whitley, who is an oblate, Teresa Bio, Sister of Divine Providence, Brigida Smiley, CCVI, and John Canty, who was kind of like an advisor, a financial advisor to a lot of the groups. They were that executive committee that brought us into existence at that time. So just, maybe we can just thank them. They're not all here with us on this side, some are on the other side, but and before we end tonight too, I just want to say that in 1934 is when this process for raising the shareholder concerns was put into place after the crash of the stock market, and so people said that if you had money in the stock market, you should have some voice. So it was like one share, you had a voice. And so this process has been in existence since then, and it's under tremendous assault is the best way to put it at this point in time. I think we've been telling you all of these years that since the end of this president's last year in office, as they left office, they tightened the amount of shares that we have to raise the questions, and they also raise the amount of votes that we have to get from the other shareholders in order to continue the process. And right now, it seems like they want to not have the process at all. So, that's what we're fighting every day. So, all of the things that Lydia had mentioned, about the resolutions that we filed this year, we don't know what 2026 will bring. So, just to let you know that next year, we don't know what we'll be telling you exactly, in that sense, because we do our research. The companies don't like the questions. They don't give us the answers that, we think they ought to, but just so you know that this is the path that we're on right now. And it's a hard path for all of us that have engaged in this work ICCR started in 1971. And so, we're asking you to keep fighting with us for shareholder rights, because if we lose those, it'll be very difficult for us to get those back. I don't know a better way to say it, but if somebody knows, So as we end tonight too, I just want to lift up Pope Francis and all of the different things that he's written. We use them all so many times, Laudato Si, but many of his other writings and everything. And, you know, just he raised up that fragility of life, but fragility of our creation and our earth. And so, you know, I know he's in eternity and, you know, going to be enjoying that. And we're still here to defend our earth and everything that, you know, that we have to go with it. So I thought that maybe as we end our program tonight, I can't lead it, but maybe somebody we could lead it, that we could sing happy birthday to our earth, because it's actually Earth Day and we rarely ever meet on Earth Day to end our thing tonight, our sessions tonight, and have a safe journey home. So I'm going to ask if anybody has a good voice. Okay, somebody's pointing to someone. Anna, can you start us? Happy birthday. And many more. Thank you so much and have a safe journey home. So.